Hello, my name is Michelle Wolf, and I'm with St. Louis University Graduate School. I am with the Advanced Practice Nursing School, and I am an ACMP grad student, and I will be presenting a video presentation on asthma education and emergent care visits and admissions. A little asthma background information. Asthma continues to be a condition that many emergent care and emergency rooms see a year. CDC reported in 2004 that 14.7 million adults visited outpatient clinics. The emergency department saw 1.8 million people in 2004. Those that were hospitalized for asthma in 2004 was 497,000. Finally, mortality in 2003 from asthma was 4,055, with children having fewer deaths than adults. Asthma also has morbidity consequences for the asthmatic in adult and late life. The question: I would like to propose that if an inpatient or outpatient asthma education program were offered to asthmatic patients, would the rate of ED visits as well as admissions decrease post-education? Some of the search engines that I used was Ovid, PubMed, the Cochrane Library, clinicaltrials.gov, and CINAHL. Some of the search words I used was asthma education in adults, as adult asthma education, emergent care and asthma education and emergent care. The search filters that I used was pretty much from NLinks. I used the intervention filter, and you'll see it right there on that slide, that great big one. The criteria for my question, the inclusion and the exclusion. Studies that included, this is inclusion criteria, studies that included participants ages 13 and older, English printed studies only, and randomized controlled trial studies. Exclusion criteria was no studies whose participants are only less than 13 years old or pediatric only studies. Since I am an ACMP student, my population tends to be 13 and older, so I figured I'd work in that scope. Of course, no non-English studies. I can't read Spanish. And no case series or individual case studies, control studies. The studies that I identified from my searches: I found 3 systematic reviews from the Cochrane database, one from 2007, one from 2002, and one from 2000. Just by my search alone, minus the Cochrane database, I found 8 adult studies were identified, and these were separate from the Cochrane database 2007 references, which you actually could find my studies, those 8 studies, in the 2007 Cochrane systematic review anyway. I decided to evaluate 8 of the 12 studies from the 2000 systematic review to address asthma education and decrease ER visits and admissions. The 8 studies are being used to evaluate a subset of the systematic review and not the systematic review at all. I was told that critiquing this systematic review probably not a good idea because it's Cochrane and it's probably pretty good, and it really is pretty good. I'm basically just reviewing those 8 studies and seeing if there is, in fact, a trend with asthma education and decreased ER visits and hospitalizations. CEBM level of evidence grading. 4 of the 8 studies received a level of evidence designation of 1B. The other 4 of the 8 studies received a level of evidence designation of 2B. CEBM with study grading, 3 of the 8 studies received a grade of A. The other 5 of the 8 studies received a grade of B. So what's my results? From the 8 studies, 4 studies did asthma education on an outpatient basis, 3 studies did asthma education on an inpatient basis, and 1 study did asthma education, but it was in the form of an intervention pack. Basically what it was is people came to the ER when they were discharged. I got this little fanny pack that had prednisone as well as some other meds, written instruction on the medications, some facts about asthma, and then 2 taxi vouchers for patients to use to follow up with their PCP. This study was primarily concerned with patient PCP follow-up post-ER discharge in asthmatics. It does mention ER admissions and readmissions, or ER visits too, but the problem is it doesn't specifically give you a number. It says the intervention group had fewer readmissions or ER visits, but it doesn't specifically say. And then as far as hospital admissions, each group was pretty much equal. 3 from the control and 3 from the intervention group. So I kind of included it, but only just because It does mention it, but not very much, and it really doesn't tell me a whole lot. Overview of results continued. 4 RCT studies saw a decrease in ER visits and hospital admissions post-education intervention. 3 RCT studies saw no change in post-education intervention group and the control group. 1 got a mix of results over the 12-month study. The first 4 months post-education intervention, the hospital admissions and ER visits decreased in the intervention group. But the last 4 months of the study, there was no difference in ER visits or hospital admissions for the intervention and control groups. Some major study problems that I identified. Big one was compliance. Brown, 2006, had a very heavy-duty non-compliance program. 39% of people did not even do the education intervention. You know, they were randomized to the intervention group, and they agreed to it, and then they never did it. And another one that got it was Bolton, 1991. That was the one where it saw, first 4 months it saw, decrease ER and admissions, and then the last 4 months there was really no difference. Again, compliance was a big problem. 41% did not do the education at all. 29%, or 28%, I stand corrected, 28% did at least one education intervention, and 31% attended all 3. Both authors admit that it's going to be hard to say whether or not education helped or didn't help because of the non-compliance. Some studies have small study populations to start with, and then loss to follow-up. Death and compliance makes that group much smaller. Again, when you get people with non-compliance, it makes that 100 much smaller, because now you only can get information off the ones that did actually, complete the study and did some of the education. Also, a lot of studies like to eliminate those people, or of course the people of death, and really it should be considered according to the census. Inpatient or outpatient? Were inpatient better than outpatient educations? It's kind of a toss-up. Inpatient saw 2 studies that had decreased ER visits and admissions, and 1 that didn't see any difference. Outpatient had 2 that saw decreased ER visits and admissions, 1 that didn't see any difference, and then of course the one that had the first 4 months had a decrease, but then the last 4 months didn't. And then to generalize or not to generalize, some of the studies actually had quite a few females, so some people might argue it's hard to generalize to males. Some studies excluded people with comorbidities, and a lot of people do have comorbidities, so it's hard to not to generalize that population to the people who have comorbidities. The education format for each study, they actually did a very good job. The education format of each study showed that the information was trying to keep with the National Heart, Lung, and Blood Institute's 4 key components, which was assessment and monitoring, education, control environmental factors, and comorbid conditions and medications. Coming soon, National Heart, Lung, and Blood Institute is doing a study right now, asthma patient education in the emergency room. They're recruiting right now, and the study is still ongoing, so it probably won't be done by the time I do this presentation or by the time I do my manuscripts. But that is coming, so maybe that'll be some information that'll help add to the current ER and admissions asthma education pool. So in summary, there is some indication that an inpatient or outpatient asthma education intervention may decrease ER and hospital admissions. There are some factors that prevent knowing if asthma education can decrease ER and hospital admissions. It is a good topic to research further because ER visits and hospital admissions are a couple of risk factors predicting the morbidity and mortality from asthma. I thank you for watching, and those from SLU who have watched this, I look forward to hearing some of y'all's critiques and maybe some suggestions on what to do, or better yet, maybe some creative input. I am debating on non-randomized control trials, but really, DeCenso says if it's an intervention, you really should use RCTs. So I thank you for watching, and y'all have a good day.